Hello, everyone. Welcome to your online lecture for our pharmacology class. This is an introduction to pharmacology. I think it's important for us to kind of just start here first to make sure we're all on the same page with kind of the definitions that we're using. This is a pharmacology class, and you all might be thinking, why 8 weeks on pharmacology? What we know about the field of athletic training is we are finally starting to get recognized as healthcare practitioners, and that couldn't excite me more. But then what it also means is that there's this greater expectation for the things that we actually know and the ways in which we're able to communicate with healthcare practitioners across the country, right? Across the medical field. And so pharmacology is a key part of that. When we think about how we treat patients, how we interact with patients, I think the common threshold for us is rehab. We're really strong with rehabilitation. In terms of treatment, most often we're thinking about the traditional forms of treatment in athletic training, right? Whether that's therapeutic massage, whether that's therapeutic modalities, icing and heating and stretching and electrical stimulation. But how often do you actually think of pharmacology in your treatment protocol? And how often do you think about what effects those drugs your student athlete is taking might have on their performance or might have on their rehab process? And so knowing and understanding pharmacology and the common drugs that your patients might encounter in the field will become extremely important. I hope after this class you'll start to think more holistically about what it actually means to treat patients, right? And so one of the things that I think is important with any class where we're really diving deep into some content that we might not be excited about is really to give you a holistic look at things. And so I started searching the literature for the number of prescriptions that had been filled in the last year. And then lo and behold, I actually found something even better. And so what we can see here is currently to date in 2023, 4.83 billion prescriptions have been filled by patients. I don't know if that scares you or not. Let me say it again. 4.83 billion prescriptions have been filled. And that number is hypothesized to continue to rise over the next 2 years. So what does that mean exactly? Like if you're actually looking at this and thinking about it and deeply processing this, you're going to encounter a patient who has some type of prescription or who is on some type of prescription medication or maybe has taken some type of prescription medication. And you're going to have to be able to work with that patient as you're treating them, right? So having a very good understanding of pharmacology will become extremely important. So these are prescription drugs, right? We know that prescription drugs can only be filled after a physician writes a prescription and you take that prescription to the pharmacy and the pharmacist then hands you the drug. But what's more scary to me is when I look at the number of over-the-counter medications that have been purchased over the years. So if we look way down here in 2002, about 13.6 billion over-the-counter medications had been purchased. And then we go way up here to 2022, we can see that 41.2 billion over-the-counter medications have been purchased in the year 2022. We can imagine, like, if we were to keep drawing this kind of graph out, we know that 2023 probably even more over-the-counter medications were purchased, so forth and so on. So again, these are more readily available, right? Because what do we know about over-the-counter medications? They don't require a prescription from a physician, making them more easily accessible, but often more often abused, right? So it becomes important for us, whether we have a patient on a prescription medication or we have a patient on an over-the-counter medication, it will become important for us to at least have an understanding of what a drug is, what does pharmacology mean, what does it mean to the field of athletic training, to you who are getting ready to graduate shortly, and then we'll have to make treatment decisions and work with physicians who are prescribing your patients medications. What does all of this mean to you as a healthcare practitioner? So let's start with, first and foremost, the definition of pharmacology. And if you're anything like me, you could probably break this up and go, ology means the study of, and then pharma, medication, right? So the study of medication. But really, if we take kind of a step back and really define what pharmacology is, there's two key kind of principles. One, we're going to call pharmacodynamics, and that is where we look at the effect of the drug on the body. And this is what we most often give patients drugs for, right? We want to reduce inflammation, we want to reduce pain, and so we'll give a patient an anti-inflammatory drug or an analgesic to do those things, and that would be the effect of the drug on the body. The effect would be reductions in pain, reductions in inflammation, right? So this is what we the therapeutic response that we expect to see when the patient is actually taking the drug. Then we have this concept in pharmacology called pharmacokinetics, which is not the effect of the drug on the body, but actually the effect of the body on the drug. So how well does the body absorb the drug? How well does it distribute it to its key kind of receptors? How well does it metabolize it? And then most importantly, probably, is how well does it actually excrete it once we're done using it and processing it and it has its therapeutic effect on the body. And so let's go here. I'm a picture person. I really like to look at things in the human body from a picture perspective. It helps me kind of connect things to my patient sitting in front of me. And so one of the things that I talked about is pharmacodynamics and then pharmacokinetics. And pharmacodynamics, when we think about that, is the effect of the drug on the body. Dynamic. The drug is having a dynamic interaction. Another way to say that is what physiological or biochemical changes is the drug actually having once the patient ingests that, or once it's injected, for example, or once it's rubbed onto our patient, right? So that's going to involve a few things. We have to consider how often the patient is taking it or dosing, right? Is it every 2 hours? Is it every 4? Is it every 6? We have to understand when we give a drug, do we have enough receptors available for the drug to actually bind to it to create an actual effect? And then we have to consider the potency, right? And potency is an extremely important concept in pharmacology, right? When we think about potency, one of the things that separates a prescription drug or a controlled substance from an over-the-counter drug is the potency of the drug, right? We know that over-the-counter medications have lower potencies and therefore less risk for the development of addiction, less risk for the development of adverse events, right? Unless, of course, they take it outside of the dosing range. Where our prescription and our controlled substances, on the other hand, are way more potent, which is why they need to be prescribed by a physician and they need to be filled by a pharmacist, right? Now, on the other extreme of that, while we're selfishly wanting the drug to have an effect on the body, what we also need to do is look at, once that drug is in the environment, what effect is that environment going to have on the drug, right? What effect is that body going to have on the actual drug itself, right? And so in order for a drug to really exert an effect, the body has to be able to absorb it, right? The body has to be able to then take the drug that was orally ingested or injected or rubbed into the area, has to then go ahead and distribute it to its target site, right? And then we have to metabolize that. And then more importantly, we have to be able to excrete that, right? And patients who have a hard time excreting the drug that is left over, oftentimes we can see how a drug toxicity might exist, or maybe an overdose. We take too much of a potent drug. We cannot distribute it or metabolize it well. And so that drug sits in the blood, becomes static, and now we have a drug overdose occurring, right? So we can see how pharmacology, while yes, it's the study of medicine or the study of a medicine on the body, we really have two key concepts. What effect is the drug going to have on the body? Pharmacodynamics. What is the effect that the body's going to have on the drug? And the two, they go hand in hand. In other words, if we have a breakdown in the pharmacodynamics, then we don't see as good of results from the drug. Maybe the patient's pain isn't reduced. Maybe their swelling isn't going down, for example. Blood sugar for diabetes, right? Maybe blood sugar isn't dropping quick enough. And then same thing for pharmacodynamics. If we can't absorb well, if we don't have enough receptors, similarly, or if we excrete too soon, too fast, then the drug can't have an effect on the body. So the two concepts go hand in hand when we think about all of the treatment goals for a patient who is actually taking a medication. So let's define drug. If you've ever wanted to spark kind of a heated debate in a group of people, just ask them how they define a drug, right? And so we will use this definition for the remainder of the class. And to be quite honest, in the field of athletic training, this is the globally accepted definition of a drug in the National Athletic Training Association. So this should be what you at least start with. That doesn't mean that you don't change your mind kind of as you branch out and you start to work with other healthcare practitioners. So hear me clearly. I'm not trying to tell you what to think. Trying to tell you what we as a professional body would use to describe a drug. So drug is a chemical, right? And that chemical, we're going to look on the next slide in just a few seconds at a table where you will see a drug has a chemical name. So there are chemicals that come together that create a drug. And the whole idea and concept is that it's a chemical that has been demonstrated to be effective at preventing or treating what we could say is a disease. And now that disease can be widespread. That disease could be cancer, right? That disease could be just inflammation. It's a change in the state of the body, or pain, for example, or suffering from a migraine. So all that to say, it's a chemical that has been put together, or chemicals that have been placed together to be effective at reducing some type of symptom that the patient is actually presenting with, right? Now, if we look down at the next bullet point, we can see it's a chemical molecule, or I would even add an S to that. It could be chemical molecules, plural, that kind of come together, that were developed exogenously in the external environment, that then get ingested into the living system to have a biological effect or response, right? So you can define that either way, but the moral of the story is we have this chemical compound that we create, and we hope that it's effective at reducing the sign or symptom that the patient came to us in the clinic for, right? And in athletic training, we can think of mainly the Tylenols and the ibuprofens and the cough syrups, right? Or the allergy medications such as like a Benadryl or a Claritin. I'm giving all of kind of the over-the-counter medications that we might actually be responsible for in the field of athletic training. So let's talk about the different names that a drug can actually have. There are 3 different names that a drug will have. It begins as a chemical name. So the chemical name is the first name, right? These are the chemical molecules that are used to make up the actual drug itself. So now the reality is we couldn't market the chemical name. No one would buy a drug that had this as its name, right? So it begins as a chemical name, and that chemical name is based on its chemical structuring, right? And then next, what happens, we'll move to the left of this table, we get what we call is a non-proprietary name. This is the name that's going to be accepted by a competent scientific body or authority. And you can see here, the generic name is most often just one. There's usually only one generic name for each drug that is developed. So for each chemical name, we have one generic name. Now, these are the ones, the acetaminophen, the ibuprofens, the fluoxetine, HCl. These are the ones that are going to be owned usually by the company that kind of develops the drug out of its chemical name, right? And then what will happen is companies will start to develop their kind of own drug based on the chemical name and the chemical structure. And that's where the brand name comes in. So the brand name is a proprietary name. Most often it's selected by the company or the manufacturer that is going to be marketing the drug. So you can have multiple companies marketing the drug, right? Those multiple companies then come up with their own brand name. Example, acetaminophen is most often known as Tylenol. But if you go down into maybe Point Loma's athletic training clinic, you'll see that when they buy the single unit doses, they buy what we call is APAP. So this is an acceptable drug that has the chemical structure in it, but may have some additives. For example, ibuprofen is the generic name. It's the one that's accepted by our scientific community. But then you have a company who then purchases it and then markets the drug as Motrin or Advil. All in all, they have the same effect, right? To reduce pain and or inflammation. You can have multiple brand names, as you can see here. And in addition to that, some brand names may vary by different countries. So I gave you an example, and it's a common example actually. Voltaren cream was most often marketed in Europe as Voltaren. And then as the United States got wind of an anti-inflammatory cream that you could rub on the skin and help reduce inflammation, then they kind of developed their own brand name. And their brand name was Diclofenac. And so that's very similar. It's an anti-inflammatory cream with the active ingredient being Voltaren. But it took on a different name. So 2 different brand names doing the same exact thing, most often with the same chemical structure. Now, we know that we have a generic name. Remember, we said on the previous slide, I'll go back, you have one generic name. That generic name is most often accepted by a competent scientific body or authority. So generic name, it makes sense, right? Every chemical structure, every drug is going to have some sort of generic name associated with that. That makes it easy, right? This is a name associated with a single drug entity. It makes it easier to pronounce compared to its chemical structure, right? But I want to be clear that a generic name and a generic drug are two different things. A generic name is a name given to a drug. A generic drug is quite the opposite, right? A generic drug is most often it's going to be marketed by other companies other than the patent owner. So if we look down here, we can see, okay, a trade name or a brand name drug. We can say, okay, this has multiple names. Usually the names are shorter and easier to pronounce. So I'm going to go back there. You can see they're a little bit shorter than their generic name, right? Then you have the generic name drug. Only one generic name exists. It refers to one chemical entity. The other thing with the generic name, interestingly enough, is it's less expensive. And then not all drugs that have generic names are marketed as a generic drug. That is so different, right? Okay, generic drugs, on the other hand, can be marketed by one or more companies. Everybody okay with this? Hopefully so. If not, we can get clarity in the discussion board. But it is a big deal to note that the generic name is not reflective of a generic drug, right? With a generic drug, oftentimes, if we go back to this slide, when we're looking at the generic name is just that, it's the name. But a generic drug, we've seen this before where companies will market a generic drug and sell it for half the price. Maybe they're using other additives within the chemical compound to make up the drug that are less expensive, and so they can sell it at a reduced cost. That generic drug does not have anything to do with the generic name. They are completely separate, kind of distinct entities all in of themselves. Okay, so as we start diving deeper, you can classify drugs by their chemical structure. Here, you can see it here, right? So classification of drugs by their chemical structure. Oh my gosh. Unless you like chemistry, then you really don't get excited about the slide, but you can see, okay, it's going to be grouped based on chemistry. Our chemists and our scientists get super uber excited about this. And if you love science and in college, then you would too. So you can look at this and say, okay, the core of this is a tetracycline structure, 1, 2, 3, 4. So you can see that tetra 4. And then as we move down here, we can see doxycycline, right? What do we know? 1, 2, 3, 4. That's the core. And then what might change is where you see these CH3s or OHs or Hs and where they are actually presenting, right? Now, we don't get excited about this, most of us as clinicians. What we get more excited about really is kind of looking at a classification based on mechanism of action, right? That's kind of where we wake up to go, okay, now you're speaking my language a little bit. So when we think about drugs being based on their mechanism of action, what we're essentially saying is they're grouped based on how they actually work within the body, how they molecularly, physiologically, how it works within the body, right? And two key examples of that are proton pump inhibitors and our beta adrenergic agonists. So the proton pump inhibitors, guess what they're going to do? They're going to block gastrin acid secretion and hopefully reduce stomach irritation over time. Another one would be that beta adrenergic agonist, right? These are going to bind to and kind of stimulate beta adrenergic receptors. And why am I saying that? Because the drugs that you most often know as beta adrenergic agonists are going to be albuterol and salmeterol. Those are asthma medications. So we want them to bind to that receptor to slow down inflammation and to reduce that asthma attack. So you can see how these drugs are grouped based on or classified based on what they do in the body mechanistically. They block, they inhibit the proton pump, or they assist agonist, right, beta adrenergic receptors to help facilitate an asthma attack. So you can see based on mechanism of injury. What we are most often used to are, drugs that are based on therapeutic effect. I think that's what we're probably most used to in the clinical setting. So they're going to be based on the condition that they are treating. So whether that's pain, inflammation, hypertension, for example. So our analgesics, right, those are going to be pain medications that are going to be used to reduce pain. So our NSAIDs or opioids are going to be an example. Our antibiotics, we know what they're used for, right, to kind of reduce infection within the body. Antihypertensive, going to be used to reduce blood pressure. Anti-inflammatory drugs were used to reduce inflammation. So we can see these are drugs that are going to be grouped based on their therapeutic effect, right? And so all that to say, as you start thinking about drugs, just know that they're usually most often classified based on either their therapeutic effect, their mechanism of action, and or their chemical structure. So just things to think about, other ways to reconsider drugs as you're starting to think through pharmacology. Now, as we look at the different categories of drugs, that's what we're getting ready to segue into. Do apologize. I don't know where else. There's no better place to put the video than in the center of the PowerPoint. So I'm moving it over here just so you can see the title, but the notes are also posted in our Canvas page. So we're going to talk about legal classification of drugs. The first one are non-prescription drugs or over-the-counter OTC drugs, right? I've already alluded to this, but as you all are aware, our over-the-counter drugs do not require a prescription, which is why we saw that like 41.2 billion drugs being purchased, because they are readily accessible to anyone in the United States, probably anyone in the world, right? The great thing about non-prescription drugs or over-the-counter drugs is that there is usually less of the active drug in the actual capsule or in the actual pill. And so what does that mean? It means there's less risk for adverse events to happen. Traditionally speaking, we don't have to monitor them. In other words, the Federal Drug and Food Administration does not have to, or the FDA does not have to monitor those, right? And if we give them at the appropriate dose, then they are way effective at what they're marketed to do, whether that's to reduce inflammation or reduce pain, or to do both of those, right? Or to reduce blood sugar, whatever that might be, to reduce a sore throat, right? So when we use these drugs as they are listed per instructions on the back of the bottle or the box, then most often they are pretty effective. And there's a reduction in the risk for adverse side effects. So all in all, what am I saying to you? That if you administer the drugs well, if the patient takes them the way that they're supposed to, most often non-prescription over-the-counter drugs can be way effective. Now, after you've treated a patient for 2 weeks and you see no decline in pain, no decline in inflammation, then that's when we move over to our prescription drugs, right? And prescription drugs, as you know, I'm just moving that quickly so you can see the title. Prescription drugs are also known as what we call legend drugs. That gets its name legend because you have to keep track of them when you compare them to non-prescription drugs. They require medical supervision. They also require a prescription, right, from an actual a practicing physician. The hard part with prescription drugs, a few things. We know that they require a prescription because there's an increased risk for adverse side effects. And those adverse side effects are going to vary. It could be an increased risk for overdose. It can be, it may cause nauseousness or drowsiness, for example, might cause an increase in headaches. So because there are more risks for adverse side effects, then they have to be monitored more and they require written prescription from a physician, right? The other concern that you have is because there's more of the active drug in these prescription medications, that there is a higher risk for the development of drug interactions. What do we mean by that? The risk of the patient having some type of adverse event overall. And then with prescription drugs, they require refills. So they're only used for a short period of time, whether that's 7 days, 10 days. I've seen some prescription drugs 3-day turnaround, one is a 1-day turnaround. So it really depends. Moral of the story is you can go buy as many over-the-counter drugs as you want to, right? Don't do that, but you certainly could. Your patient could do that too. But when it comes to prescription drugs, there is a cutoff point where they either have 0 refills and they need to see a physician to reduce addiction, to reduce adverse effects, or they have maybe 2 refills before they need to go see the physician. All in all, they don't have just complete access to the prescription drug, right? Have yet to meet a prescription drug that has an unlimited amount of refills per se. The next drug category are controlled substances. Controlled substances are extremely dangerous and are important for us to know as athletic trainers. How do we work with a patient who is currently been prescribed control medication? So we think about controlled substances, or AKA scheduled drugs. They have the highest potential for abuse. So we've got prescription drugs, which are right in the middle. We have OTC drugs, which are on the opposite end of the spectrum, very low propensity for drug abuse. Now we have these things called controlled substances or scheduled drugs, which have a high propensity for the development of abuse and or addiction. And so because of this, because they have high potency, because there's a higher risk for abuse and addiction, then they have more restriction around them. So in other words, physicians have more rules and regulations when they prescribe them, when they distribute them, and more importantly, when we store them, and the record keeping is going to be different. So let's move to the next slide where I've listed the 5 different schedules of drugs. So let's take a look at them. We have schedule 1 through 5. And if you look at this, then you might be saying, okay, the highest potential for abuse in our schedule or controlled drugs is going to be at the top. And then as we move down to schedule 5, you will see there will be less risk for abuse, but certainly still can have some abusive mechanisms. So our schedule 1 drugs, let's take a look at which drugs are actually over here. And then you'd be like, oh, okay, this makes sense. So I'm going to skip marijuana because in some places that's actually legal, but do know it is considered a schedule 1 drug and does have the high potential for abuse and addiction. But then things like heroin, for example, LSD, right? You get the point, right? These are all schedule 1 drugs. They have the highest potential for abuse. And believe it or not, in the United States, there is no acceptable medical use for it. So most often physicians would not be prescribing this in the United States, right? Next is our schedule 2. We see these actually being prescribed, but the key thing with schedule 2 drugs is they cannot have a refill. So this is the patient who goes into the clinic and gets maybe a fentanyl or an oxycodone or a morphine, for example, and then would need to go back to the physician to see them in order to get an actual refill. Here's the difference between a schedule 1 and a schedule 2. There is accepted medical use, still high abuse potential. And the scary thing is not only is there high abuse potential, but there is the ability for psychological and physical dependence on the actual drug. So these patients who are on these Schedule 2 drugs, not only when they have no refill, right? So they have no refill, you're going to have to work with them to get used to their body not actually having the fentanyl or the oxycodone in their system, because they usually develop some type of psychological, and the body develops a physical dependence, right? And that goes back to the pharmacodynamics and pharmacokinetics of pharmacology. Next up is your Schedule 3 drug. It has a lower potential for abuse. Can you see that? So less than Schedule 2, but more than our Schedule 4. The abuse may lead to moderate to low physical and psychological dependence. So these 2 patients, you really want to make sure that when they start to come off of the drug, that you really do work on the psychological aspects of recovery, right? Schedule 3 drugs can be anabolic steroids, testosterone, ketamine, right? And then we go down to our Schedule 4. The abuse potential is less than Schedule 2, but more than Schedule 5, and we can see that the psychological dependence kind of declines. But you've got your diazepam, your tramadol, for example. And then last but definitely not least are your Schedule 5 drugs. These are the medications with the least potential for abuse, and probably have the least amount of psychological dependence after removing the patient from the drug. And they include things like atropine, for example. So what we can see all in all is our Schedule 1 drugs typically are not prescribed by physicians, cannot be in the United States. Your Schedule 2, you don't have the capacity to have a refill because of the increased risk for psychological and physical dependence. And then as we move to 3, 4, and 5, we can see that patient can certainly get more refills of those schedules. So what do we need to know about the schedules? We need to know the potential for risk, right? We need to know how high is the risk for abuse, psychological dependence, physical dependence, and you need to know some basic key drugs in each of these areas. So an exam question might be, anabolic steroids is considered to be what schedule of a drug? 1, 2, 3, 4, and 5. So you don't need to know them all, but the most common ones that you might interact with: oxycodone, morphine, for example, the atropine, for example, the dextromethorphan, for example. Those are all things that you at least want to have in your tool bank as you're preparing for that exam. Okay, now I'm going to bore you a little bit, but I don't know. I kind of got a little bit excited as I was kind of reading through these items. So there are laws that really, truly do kind of keep us in check as individuals, mainly our healthcare practitioners who are prescribing or are handing out drugs. So the first one was the Federal Pure Food and Drug Act of 1906. Essentially, it prevented kind of mislabeling of drugs. So like creating a drug and then marketing it as something else. So it prevented the misbranding of medications, right? The hard part was with this particular Pure Food Act is it didn't require the drug to be safe or effective. So people could create drugs and not, for let's say, for lack of better words, not test them and not know if the drug in its form was actually safe. So they could just give them to patients. Patients might have adverse side effects, right? Then the next Food, Drug, and Cosmetic Act of 1938 came out, and it required that the safety of new drugs be reviewed. Obviously, who would have thought, and approved by the FDA. So these are all kind of like hallmarks in pharmacology, right? And this is key. This is huge, because if we go back to that Federal Pure Food and Drug Act of 1906, there was no safety testing. There was no review, right? And so we just had these drugs on the market and people were taking them. We didn't actually know if they were safe, right? So now in 1938, only 32 years later, right? I'm assuming a few deaths, a few lawsuits later, then the Food, Drug, and Cosmetic Act came out, which required that the new drugs that were on the market be reviewed, right? And they would go through this kind of review process to ensure that they were safe, right? And so this act was the beginning of what we call as the new drug approval process. And we're going to get to this long, drawn out process that every company has to go through before they can actually market a drug as safe, right? So then we go to 1952, the Durham-Humphrey Amendment of the 1938 Act. And so in this is where we get the differentiation between prescription and non-prescription drugs. They are going to be treated differently in the review process, which makes sense, right? Because prescription drugs, what are they going to have? Higher propensity for adverse effects. They're more potent. And then you have over-the-counter drugs, which don't have as much of the drug, and so they're less potent, less risk for adverse effects, right? So it said, let's treat them differently in the review process, right? And so one of the things that it did is it said, okay, drugs that were unsafe without medical supervision, they required a prescription. So they kind of started to tack down on which drugs might actually need prescriptions. We can kind of thank the 1952 Durham and Humphrey Amendment Act for prescription-based drugs, right? They kind of put the slap on the market and said, hey, some of these drugs are too potent to just be able to go and access and grab off of the counter without a prescription. Then in 1962, we have the Kefauver-Harris Amendment of 1938. So everything's kind of coming off of 1938, can you tell? Required that the effectiveness of new drugs, whether prescription or non-prescriptive, be reviewed by the FDA prior to the drug being marketed. So instead of being able to market it before it actually went through its review, now they're saying, stop. It's great that the drugs seem to be safe, but now let us go through an even more a more rigorous process to make sure they're actually safe, right? So let's look at it this way. Drugs marketed between 1938 and 1962 were included in this amendment. So we then went back and started to review the drugs that were already out on the market. And then drugs now had to be approved as safe and effective before becoming available in the public eye. In other words, they didn't just have to be safe, but we didn't want patients just taking drugs just to take them because they were safe. We also wanted to make sure that they were effective at what they were doing. If they were marketed to reduce inflammation, then we wanted to make sure that they were actually reducing inflammation. So this is going to steamroll into animal trials, drug trials, randomized control trials, and things like that in just a moment. Last but not least, we have the Comprehensive Drug Abuse Prevention Control Act of 1970. And so this is where we established controlled substances 1 through 5. So if I go back here, this is when our schedule of drugs was created. In other words, Schedule 1 was high abuse, could not be prescribed in the United States. Schedule 2, high abuse, high potential for psychological, no refill, right? That is where we kind of created the 5 schedule of drugs. So I know y'all are like, Cosby, you're killing me, but these are important dates to understand. Federal Pure Food and Drug Act. Oh my goodness, think about this. Think about before 1906. People could have created anything in their kitchen and marketed it as safe, and you could have taken it and not really known the adverse side effects, right? So this was the first time where we kind of said, wait a second, you can't just put a pretty stamp on a pill and call it ibuprofen. We really need to truly know that there's an active ingredient in there that's going to reduce inflammation, right? So that kind of catapulted the different things that you see. Ultimately, we're thankful for each of these drug acts, right? Because each of these created a pathway for what I call is safe delivery of medication. And so then now we can rest assured that if the physician is giving or prescribing us a drug, that what we're actually taking is going to do what it's purported to do, right? And that's ultimately what we want, is safety in medication. Okay, so I said there was this drug approval process, right? So I'm going to walk you through it so you can understand just how kind of tedious it is now to get a drug approved. But then just think in like 1902, they didn't even have this process. So the first thing that happens with a drug is it goes through preclinical testing. That preclinical testing takes 3 to 6 years. Now, because it's preclinical testing, sorry if you love animals, that is me too, but they did a lot of lab and animal tests. So they would give the drug to the animal to see how they're behaving. They might create some type of injury or inject some type of cancer and then give them the drug and watch and see if the drug is effective, right? If it's safe, if it's doing what it's purported to do, right? And we call that the preclinical testing. That takes 3 to 6 years. So it isn't easy to get a drug approved. I hope you all are seeing that. So then once we do 3 to 6 years of testing, then you can create what we call is an investigational new drug. And so then the FDA approval for clinical human trial testing is now approved. So you go 3 to 6 years of testing in the lab and animal tests. And then if we make it through this with very low adverse side effects, the next attempt is then now we can move to human testing. So we don't just go straight to human testing, right? After 3 to 6 years, we move into phase 1 clinical trials. Phase 1 clinical trials, again, is going to be on human testing. This is going to last about 1 to 2 years. So we're already 4 to 8 years into a drug being in the system before we even start testing on human beings. So with phase 1 clinical trials, because now we can test on human beings, we usually do this on a very small group of healthy individuals. So 20 to 80 healthy individuals. And what we're doing here is we're assessing the pharmacokinetics. What does that mean? Which part of that? Is it the effect of the drug on the body or the effect of the body on the drug? Great. If you said the effect of the body on the drug, you'd be correct. So that would be like absorption, distribution, excretion, and metabolism, right? We also want to check for safety and dosing. So how much of a drug can we give a patient before it starts to cause adverse effects, right? So we're doing dosing assessment. After 1 to 2 years, if there are minimal adverse side effects, then the drug can move into what we call as phase 2 clinical trials. Phase 2 clinical trials last about 2 to 3 years, okay? This is with larger group of patients, and these are unhealthy patients. So the drug being marketed, if it's an anti-inflammatory drug, these are patients who have inflammation in their body. And so now we're not checking dosing because we've already done that. We're not checking pharmacokinetics. Now we're looking at the safety and effectiveness. So which is that, pharmacokinetics or pharmacodynamics? Great, it's going to be pharmacodynamics, right? The effectiveness of the drug on the actual body. If in 2 to 3 years we have low side effects, low adverse effects, then we move into phase 3 clinical trials. And when we look at phase 3 clinical trials, you're looking at 1,000 to 3,000 patients. So larger group of patients. We're looking for are adverse effects, right? And again, effectiveness of the drug. But the big key thing here is going to be adverse effects. Now you saw something else drop out, right? Because at this point, if we've gotten through phase 1 and phase 2, we're about 9 to 10 years into drug testing. So if we get to phase 3 and if we pass through phase 3, then we can finally submit for a new drug application. This is the application that we would submit to actually have the drug in its chemical structure and in its generic name now being marketed, right? Okay, so then the next step is, okay, if we submit the new drug application, then the FDA will review that, and if all is positive, then you'll get approval for physicians to prescribe. And we move into what we call our phase 4 clinical trials, which are about 1.5 to 2 years. And in there, what we're doing is just prescribing the drug to the general population, and we're monitoring for adverse side effects. We're also comparing it to other therapies that are on the market. So all in all, you can see it takes about 10 to 11 years for a drug to kind of make its way through and to actually be marketed either as or purchased by a company in its generic name, and then to be marketed in the company or on the shelves as its brand name, right? So this is a very robust process. That robust process, I would go back a slide, but I can't because of all of the clicks. But that robust process began with all of those acts that you see. So that's why it's important to understand the 1902 Act, the 1938 Act, and the acts that subsequently followed, because it created the drug approval process. And in creating that drug approval process, one of the great key things that came out of that was really this concept of, we want to make sure that these drugs that we are giving individuals are safe. If nothing else, they're safe. They're free from the potential of addiction. And if they have high potential for abuse or psychological, physical dependence, then there's one refill or no refills, or we're monitoring that more closely, right? Okay. Now we have things that are called drug recalls, right? Because we get something out on the market, lots more people start to take that, right? We said 1 to 3,000, but the reality is we know that there's 4.3 billion prescriptions being prescribed. So the inherent reality is that as we start to move towards more patients taking this drug, we will start to see adverse effects being reported more commonly. So you can have these things called drug recalls. I'm sure you've seen them on the news. I'm sure you've read them in the newspaper, right? You can have these things called drug recalls. The big thing is, where in the category does the drug recall occur? So if it's a class 1, right? Attention, class 1 recall for whatever the commercial always says, right? Then you're worried, because that is the recall where the drug has caused severe health problems and even death in patients, right? Now you get the commercial where it's like, doo, 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 class 3 drug recall. Then you kind of go, okay, I can rest easy. If you're taking that drug, it's very unlikely that it can cause any adverse health reaction, but yet there are some people, very small percent of the population, who have suffered adverse events. So they're going to recall it to figure out what might be best. And in current news, one of the pediatric doses for the COVID vaccine actually was recalled, right? And so I'm sure they'll put it back on the market once they maybe refine the chemical structure a little bit more. But that would be an example of a class 3 recall. So you can see the differences between a class 1, very severe health problems, maybe even death. Class 2, you're in the middle, right? Temporary health problems, but they pose maybe a slight threat, or could be serious in nature, but they don't cause death, right? So the ideal would be that we would be in the class 3 recall. Most often we see the drug back on the market relatively shortly. Okay. Now, there are lots of drugs. You can see 4.3 billion prescription drugs. You also know that there were like 40 some odd billion over-the-counter drugs that were purchased. So we have to have things in our clinical toolbox that allow us to kind of, what happens if a patient walks in with a drug that we don't know, right? So we have all of these resources that are available to us. Most of them are free and are online. The Physician's Desk Reference is an actual book with colored pictures of every pill over-the-counter prescription that exists on the market. So if a patient comes in and is like, hey, my friend gave me these, I don't know what they are, you can actually take the pill, open the Physician Desk Reference, and look for the pill, and it will tell you what the drug is, what its dose is supposed to be, how often they're supposed to be taking it. It really does kind of help, right? The next thing that you have is an OTC reference book. It's a handbook of non-prescription drugs. So it's very similar to the Physician's Desk Reference. You have lots of textbooks, but those are outdated because there are so many drugs being approved on the market constantly that it is hard for textbooks to kind of keep up. My preference, believe it or not, are the phone apps. So your homework will be to download one of the phone apps. My favorite is Epocrates. It's relatively easy to use. You open up the app, you can type in the drug name, and you can see adverse side effects. You can see dosing if you're unsure. So it's kind of like quick pocket check, take my phone out. And just so you all can see, I do have Epocrates downloaded kind of on my phone. So this isn't one of those instances where I'm telling you to do it and I'm not doing it. It will force you to create an account, and that's okay. You'll use it for the rest of your life as an athletic trainer. And then what I would say is I want to encourage you as you start to move into different fields of athletic training. If you're going to work NCAA, you need to know what their drug policies are for administration of drugs in athletic training. If you're going to go maybe work with Olympic level athletes, each governing body kind of has its own set of rules regarding what student athletes can actually take. medicinally, and so it will become important to understand those rules and those laws that govern those particular bodies, so that you don't, let's say, get an athlete disqualified per se. That is the end of our online lecture. I hope that you've learned a lot about pharmacology. We will be moving into management of medications in athletic training next. Thank you for watching this online lecture.